Warahmatullahi wabarakatuh. Assalamualaikum.
Waalaikumsalam, Doktor.
Dengar tak?
Dengar.
Okey, sekejap. Sekejap. Okey, semua ada dah?
Dah.
Actually I have to admit one thing lah. Saya tunggu you guys punya slides lambat sangat semalam. You guys buat baru lepas tu you hantar
Hello?
You guys hantar yang dah siap malam?
Yang baru yang kata suruh edit jadi 10 minit tu lah.
Itulah actually I punya plan is tu lah, sorry I memang ada problem sikit dengan bagi instruction. Actually I cakap you guys, you hantar je dulu kat I biar I review and then I akan pulang balik kat you and then you tukar jadi 10 minit. Lepas tu I tunggu lama gila mana slide ni. Saya pun dah tertidur dah.
Okay, sorry Doktor.
Lepas tu pagi tadi nak tengok sorry ada emergency tadi. So pagi-pagi I dah pergi intubate patient. Lepas tu I ada workshop so tak sempat lah tengok. I tak tengok pun slides you guys. Kesian korang. Tapi tak apalah, you guys present je lah. Okay kot. Okay kan?
Okay. Cuma semalam kau Doktor, semalam kami ingat kena buat general, maksudnya tak fokus on pediatric patient sebab bila tengok senior buat pun macam dia buat general.
Itulah yang tu yang I cakap.
Semalam baru tahu.
Itulah sebab your senior buat benda sama juga. I tak tahu lecturer lain macam memang nak suruh general ke tak. So I dah comment all group, I comment benda sama. And then I thought memang lepas tu lah I pun silap juga. So I sibuk lah minggu ni, sorry sangat. Tapi I thought macam you mesti tanya senior kan. Mesti senior you bagi tahu. Tu lah, I pun tak tahu lah. Tapi sebab semua orang buat. Sebab kalau general, so what's so special about pediatric kan? Sebab it's different. Method dia tapi it's okay. So at least you know. So you boleh start lah present. Siapa first?
Afiq.
Okay, Afiq.
Okay, I will present first. Okay. Can you guys see my slide? Alright. Bismillahirrahmanirrahim. My name is Muhammad Afiq bin Azmi. I will be presenting about a blood culture and sensitivity procedure. But first, I will explain about the blood procedure for blood sampling. For pediatrics, we use two methods, which are the drop method, which is needle, and next is the syringe and needle method. I will explain with the video after this. So first, the general is drop method. We use needle to prick usually at the skin of the hand of the babies. So first, the general is apply the dermal antisepsis prior to collection, consists of brushing with alcoholic chlorhexidine. And then insert needle with opening face up until the blood flash back, and then gently squeeze the baby's hand if needed, if the blood is not dropping. And lastly, remove the needle and place the cotton on the wound. And for the syringe and needle, can be used to draw a larger quantity of blood, usually in a more child with more than 6 months old. So we use this method use syringe and needle in the antecubital fossa. Okay, then let's watch a video.
Sick babies often need several lab tests. If more than 1 milliliter of blood is needed, blood should be taken from the vein This video will show you how to draw blood 3 different ways. With a needle, with a syringe and needle, and with a butterfly. First, let the caregiver know about the procedure, then wrap the baby snugly. Now, gather your supplies. Cotton balls, either a needle, 21 to 23 gauge, a butterfly, 23 to 25 gauge, or a syringe and needle. Add a labeled blood tube, pour antiseptic on the cotton, and remember your gloves. Before you start, wash your hands. The easiest way to draw blood on a baby is to use a sterile needle. Start by finding a good vein in the baby's hand. Then put on gloves. Make a circle with your fingers around the baby's hand. Clean the skin from the center, moving outward. Do this 3 times. Let the skin dry. Stretch the skin and hold it firmly. Then, taking a shallow approach, insert the needle through the skin. The opening in the needle faces up. Barely move the needle just until you see blood coming. Hold the tube under the needle and gently squeeze the baby's hand to bring the blood. Here's another example of how to squeeze the baby's hand. This method cannot be used for blood cultures, as it uses an open tube and so is not sterile. When you have the amount you need, remove the needle and cover the site with a cotton ball. Then safely dispose of the needle. Here, we draw blood using a sterile needle and syringe. Find a good vein. Then tie the tourniquet so you can easily release it. Put on your gloves. Then clean the skin well 3 times and let it dry. Stretch the skin and hold it firmly. Now, insert the needle through the skin. The flashback of blood shows that you're in the vein. Pull back very slightly on the syringe and then continue to hold. Let the syringe slowly fill. Be patient. Pulling back too forcefully will collapse the baby's tiny veins and you will not get blood. Draw up the amount of blood you need. Release the tourniquet. Remove the needle and cover the site with a cotton ball. Fill the labeled tube and safely dispose of the needle. The third way uses a sterile butterfly device. This is more costly, but like the needle, can be easy to maneuver. Find a good vein. Then tie the tourniquet so you can easily release it. Carefully clean the skin and let it dry. Hold the skin firmly and insert the needle. Move the needle slightly until you see a flash of blood in the tube to show that you're in the vein. Uncap the end of the device to draw the blood into the tubing. It then drips into the tube. In this second example, a syringe is attached to the tubing. Pulling up slightly on the syringe draws the blood into the tubing. Be aware, if it fills too slowly, it can clot. Let it fill the syringe until you have the amount of blood you need. Release the tourniquet. Remove the needle and cover the site with a cotton ball. Then safely dispose of the butterfly device.
That's all for the blood sampling method. And next is the common microorganism that can be found when cultured in pediatrics. The first is the coagulase negative staphylococci, the Klebsiella pneumoniae, Acinetobacter baumannii, and so on. So the right side is the sensitivity for the sensitivity test. Like this one is a third generation cephalosporin good evaluation, and then next and so on. I will talking about the how the blood is cultured. First, when we collect the blood sample, like in the video, we for pediatrics we usually take around 1 to 3 milliliter, and one bottle is enhanced to growth of aerobic organism in this one, and the other is for anaerobic. For pediatric, usually it is aerobic organism only because it is more common. So the single aerobic bottle may be collected to minimize the amount of blood required. And it is recommended to at least 2 sets are collected from 2 separate venipuncture locations. And this helps to distinguish the contamination due to procedure before, as contaminants are less likely to appear in more than 1 set than through pathogens. The blood culture contains growth medium, which encourage microbes to multiply, and an anticoagulant that prevents blood from clotting. Usually, the sodium polyanethyl sulfonate is commonly used because it does not interfere with growth of most organisms. The exact composition varies, but aerobic bottle use a broth that is enriched with nutrients such as brain heart infusion or trypticase soy broth. And an aerobic bottle typically contains a reducing agent such as thioglycolate. And the empty space in an anaerobic bottle is filled with gas mixture. It does not contain oxygen. And this is the signs of growth in a manual blood culture systems. This one, A form of growth, pellicle on the surface. B is the bubbles from gas production. C is turbidity from microbial growth. And lastly, visible microbial colonies. And this is for the cream stain from a positive blood culture bottle showing spherical bacteria or cocci that stain the purple. And right, if the growth of Staphylococcus aureus, a gram-positive coccus, and a pathogen commonly isolated from blood cultures. And this is the manual antibiotic sensitivity testing by the disk diffusion test. You can see that the larger the radius is, the better the antibacteria or antibiotic it is. And this is the pre-formulated panels loaded into this instrument, which is an automated antibiotic sensitivity testing. And these are the common complications for the venipuncture procedure, such as fainting during the collection of the blood sample, either the parents or the child, hematoma, allergies, especially to latex, hypersensitivity reaction, and lastly, infection. And that's all from me. Thank you. Are there any questions? Mm,
I have a question.
okay.
How do we ensure that the needle does not penetrate the vein from front to back or just inside the lumen?
We usually once we puncture the skin, we we rotate the needle slightly until it enter the vein. Until when there is a flashback, then it is in the vein. Like this, right? We once we puncture the skin, and then we try to rotate the needle, and then there is a flashback of blood. Then that we will know the needle is in the vein. Does that answer your question?
Oh, okay. Thank you.
Okay, ada soalan lagi? Sorry, tadi saya termiss sebab saya dalam lift. Okay, ada soalan?
I have a question. Which one is more common, change and needle method or drop method?
Usually in neonates, we use drop method because the blood is hard to get from the antecubital vein. So we use this method for neonates, and for child which is more than 6 months, we can use syringe and needle method. Okay.
Okay,
Okay.
usually syringe and needle method we don't do in small children because bila you experience and they can collapse, the pressure can actually collapse the vein, so it's quite difficult Okay, good.
Okay.
Anyone
Thank
else?
you.
Okay, kalau tak ada, so next.
Okay.
Can everyone hear me and see my screen? Hello?
Yes.
Yeah.
Yes.
Okay. So, Assalamualaikum warahmatullahi wabarakatuh. My name is Nabila Mehdi Safril, matric number 1810918. And today I will present a continuous bladder drainage procedure. So the indications for this procedure is for the diagnosis purpose. First is to collect sterile urine sample, specimen, and then for accurate measurement and monitoring of urine output or for urodynamic studies. And for therapeutic purpose is to relieve urinary retentions, for bladder irrigation, which is to remove blood clots from the bladder, intermittent decompression for neurogenic bladder, or to empty the bladder before, during, or after surgery. The contraindication is when the patient has suspected urethral injury, such as when the patient has radial injury or fractured pelvis. There are three types of catheter. The first is external catheter, which is, for example, condom catheter, but this is usually indicated in adult or in men. And then second is urethral catheter, is further divided into indwelling urinary catheter, which is most commonly used in the hospital settings, and then intermittent urinary catheter that is inserted several times a day to drain the bladder and then is removed. So each time a new catheter is used. The third is suprapubic catheter, which is inserted through a hole in the abdomen and goes directly into the bladder. It is performed under anesthesia and used when the urethra is damaged or blocked. That's prevent from insertion of the urethral catheter. So this is a parts of the Foley catheters. Yes, eyelets that drains the urines. And then the balloons that is inflated to keep the catheter in place in the bladders. And then the port for the balloon inflations. And then the catheter is connected to the drainage tubes, and then it goes to the collection bag. The sizes of the catheters for pediatric patients, it is based on the weight and the age of the children. So usually use range from 6 Foley to 14 Foley for the adults. And then for the preparations of the catheterizations, the first is the preparations of the child and the family. First step is to gain the patients or the primary caregivers consent for the procedures. And then they should be given a detailed explanation regarding the procedure. Next is the preparations for the environment and equipments. Make sure that the patient's privacy is maintained and they are kept warm during the procedures. Ensure there is adequate light to perform the procedures. And these are the equipments that are needed. For the lubricants, usually for the infant, we use the sterile lubricant. For the insertion of the Foley catheter, first step is to place the waterproof pad under the patient to prevent the soiling of the pad, and then position the female patients in dorsal recumbent positions, and for the male patient, position in the supine positions. Then place a blanket or sheet to cover the patients and expose only the required anatomical areas, and apply clean glove, and wash the perineal areas. Then perform hand hygiene and attach the urinary bag to the bed and ensure that the clamp is closed so that the urine does not leak from the urinary bag. And then apply sterile glove and wrap the patient with sterile wraps, either using sterile glove or using ungloved hands, and only touch the outer edges of the wrap. And then lubricate the tip of the catheter using sterile lubricants and check the balloon inflations using a sterile shrinks. And place the sterile tray with the catheter between the female patient's leg. For the male patients, place it next to the legs. For the female patients, to clean the perineal area, separate the labia with the fingers of the non-dominant hands, and use the dominant hands to clean the labia and urethral meatus from clitoris to anus, and then from outside labia to inner labia folds and to urethral meatus. For each cleansing stroke, make sure to use new cotton swab and sterile forceps. For the male patients, hold the penis at shaft at right angle to the body with the non-dominant hands, and then using dominant hands, clean the urethral meatus in a circular motions, working outward from the meatus. Also, for each cleansing strokes, use new sterile cotton swabs and sterile forceps. For boys that is older than 3 years old, insert the xylocaine gel into the urethras and then wait for about 2 to 3 minutes for the local anesthesia to work. And then insert the catheters until the urine flows, and then when the urine flows, advance more, 2.5 to 5 centimeters. Inflate the balloons using distilled water and gently pull the catheters until resistance is felt. Then connect the catheters to the drainage system and secure the catheter to tie. Position the drainage of the bag lower than the bladder so that the urine can flow, and dispose the glove and dispose other equipments. Perform hand hygiene and document the procedure. Next is how to remove the Foley catheter. First is perform hand hygiene and set up supplies. Then apply non-sterile glove and measure, empty, and record the contents of the catheter bags. And then remove the glove, perform hand hygiene, and apply new non-sterile glove. Remove the catheter skimmer device. Then perform the catheter care with warm water and soap, and then insert syringe in the balloon pores and drain all the fluid from the balloons. Verify the balloon size to make sure that all the fluid has been removed from the balloons. Pull the catheter out slowly and smoothly. And then wrap the used catheter in a waterproof pad or glove. Unhook the catheter tube from the urinary bags and discard all the equipment and supplies. Remove glove and perform hand hygiene and document the procedure. Next, for the suprapubic bladder catheterizations, for the percutaneous cell linear techniques, the distensions of the urinary bladder is a must for this approach. It can be done physiologically either through urinary retentions or with the end of cystoscopes. The cystoscopic examinations allow direct visualizations of the puncture needle, but it may not be required. And then first step is in an area about 2 fingerprints above the pubis, insert the needle until the urine is aspirated. And then place the gate wire through the needle and then remove the needles. Advance the dilator over the wire to enlarge the tracks. Then the dilator is then replaced with a sheath, and then remove the gate wire and place the catheter through the sheath, which is then peeled away. Inflate the catheter balloons and gently withdraw the catheter until a slight tension is felt. Then connect the catheter to the drainage systems and secure it to the patients. I think you should watch the video. This is the yesterday's video. So first, place the needle in the urinary bladder, and then insert the gut wire through, and remove the needle, and then place the dilator to enlarge the tract, and remove the gut wire, and then insert the catheter through the dilator, and then inflate the balloon using distilled water to keep the catheter in place, and pull and remove the dilator, and then connect it to the urinary bag. And done. The complications of this procedure is it might causes catheter-associated urinary tract infections such as urethritis, cystitis, pyelonephritis, or transient bacteremias. It can also cause paraphimosis, which is common in children. That might cause swelling and painful retractions of the foreskins due to failure to reduce the foreskins after the catheterizations. Creation of foul passages. This occurs when the catheter is pushed through the urethral walls when inserting. Urethral strictures, urethral perforations, bleedings, and non-infectious complications such as acinator removals of the catheter, catheter blockage, gross hematuria, or urine leakage. So that's it. Thank you. Any questions?
Assalamualaikum. Okay lah, that's better. So how do you differentiate between CIC, intermittent catheterization, dengan CBD, continuous bladder catheterization?
For the intermittent is only inserted when we want to drain the bladder, and then it's removed once the urine has been drained. For the continuous, it can be inserted for like 3 to 6 weeks.
Okay. Okay. Is it the same catheter we use?
Yes. The FOLEY catheter.
No, kita tak guna same catheter. Okay. Untuk CIC, intermittent catheterization, kita guna CIC catheter. Dia ada specific catheter for that. Okay. If there's no CIC catheter, we can use Ral's tube. Nasogastric tube. In fact, in neonates, biasanya kita guna nasogastric tube. Kita tak guna Foley catheter. Neonates, biasanya kita guna nasogastric tube. Maksud tak ada inflatable balloon lah hujung dia. And then, tu dah. Tu cukup. Ada soalan? Okay, tak ada. Okay, tak ada. Next. Okay, good.
Next, I'll be sharing about central venous line insertion. Sekejap, Okay, Assalamualaikum warahmatullahi wabarakatuh. So today we're going to learn about pediatric central venous line insertion. So this is the various central venous access devices that we can use, which are the central venous catheters, which we will learn today after this. But there are also other types, which are PICs, peripheral inserted central catheters, implantable port, and umbilical artery or umbilical vein catheters. The pictures below is the PICs, and this one is the implantable port, and this for the umbilical artery or vein catheters. And then what is actually the indications for this central venous line insertion? The first one is to provision of medications such as antibiotics, or also to administer chemotherapeutic agents. And it can also be used to administer blood products and to draw blood, especially for repeated blood sampling. And then we can also use for parenteral nutrition media or prolonged intravenous access, or when peripheral access cannot be achieved, such as when the patient is having burns. So we opt for central venous line insertion. And then we can also use this in very ill children who need secure intravenous access, and also to monitor the CVP, central venous pressure. So this CVP is actually the pressure that we measure close to the right atrium, and this indicate the right mean atrial pressure, and we usually use it as a guideline for fluid management. And then for the contraindications, relatively when there is obstruction of the vein by tumor or mass, or when there is a distorted anatomy of the vessels, so we will try to avoid using the central venous line insertion, and also when we can achieve the same objective by using peripheral line, but this depends on the situation. And then when there is bleeding and coagulopathy disorder, and cooperative patients, or lack of consent. And absolute contraindications is when there is infection of the overlying skin or soft tissues, because we don't want to accidentally inject the organisms into the blood and cause septicemia, etc. And then when there is thrombophlebitis, which is inflammation of the vein. And then next one. So for central venous catheters, there are three locations which we can insert the catheters. The first one is either at the jugular vein at the neck area, or at the subclavian vein, the shoulder, and also at the femoral vein at the groin area. So, firstly, all patients must be properly secured and sedated to ensure the minimal movement. And it is important for the children to be what we call that, to be given general anesthesia, which differs from the use of local anesthesia in adults. And this is important because movement of just few millimeters of the needles can determine the success or failure of the procedure. And then we apply the antiseptic solution. We usually use chlorhexidine and alcohol, and then we drip with sterile towels. And then after that, we usually use Seldinger technique, which involves three components, which are the needles, the wire, and also the catheters. So firstly, we try to detect the vein by using the introducing needle, and then when the needle is punctured into the vein, we threaded the wire into the needle, and then threaded the wire into the needle, and then we remove the needle, and we put the catheter over the wire, and then we remove the wire, and this will left the catheter. This technique is also has also been explained by Nabila just now, so it is the same technique. And then for the approach, uh, for gaining central venous access, there are three locations, as I mentioned before, right? Internal jugular, femoral, and also subclavian. So for the internal jugular approach, we usually prefer the right side because the parietal pleura of the right lobe is lower, and also it is away from the thoracic duct, which is located at the left side. So the patient is usually being placed in translumbal position, which is this position, where the head is downward and the feet is elevated. This position was promoted because to improve the venous return to the heart, to improve the cardiac output, to increase the cardiac output, and also to improve the perfusion to the vital organs. And then the head is rotated approximately 15 degrees to the left, and we look for the apex of the sternocleidomastoid. This apex, as you can see in this picture, okay, this picture, this is a triangular shape. You can find it by yourself. You can do it on your own self by standing still, and then you palpate the sternal notch at the center, and then you go laterally while your head is turned towards the left or right. And then the first elevation is the um, sternal head of sternocleidomastoid, and then you go more laterally. This one is sternal head of the sternocleidomastoid, and then it goes more laterally. This is the clavicular head of sternocleidomastoid, and then in between this is the triangular-like depression, right? So the tip of this triangle is the apex of sternocleidomastoid, which is the location that you usually insert the needle for internal jugular approach. So for this internal jugular approach, there are actually three entries, which are central, anterior, and posterior. Just a quick explanation. For the central, we insert the needle in between the head of the sternocleidomastoid. This one, the blue one, and then we insert the needle in about 30-degree angles. And then for the anterior, we insert the needle medial to the sternal head of the sternocleidomastoid, and then make sure that the needle is lateral to the carotid pulse, that we can palpate in the medially to the sternal head of the sternocleidomastoid. And then for the posterior approach, when the needle is being inserted at the lateral side of the clavicular head of the sternocleidomastoid. Okay, and then for the subclavian approach, which is quite uh, uh, the most preferred route because it offers the patient greatest mobility. Also, this preferred the right side, and intra the lumbar position, but the head just in neutral condition, and but the arm must be abducted, and then the needle is inserted inferior to the clavicle. At the middle cut of the clavicle, we goes about 1 cm below the middle cut of the clavicle, and insert the needle about 30 to 30-degree angle into the supraclavicular notch. This one, notch, into the supraclavicular notch, towards the supraclavicular notch. And then this one for subclavian approach, and the last one for femoral approach. It is very rare to use this femoral approach because of the high maintenance, because this approach have high possibility for infection to occur, and also for the thrombosis to occur. So, but then we use femoral approach when we want to do temporary hemodialysis or pharesis catheter, or when we cannot access other primary central veins as a consequence of thrombosis or stenosis, or when we want to do CPR. So we opt for femoral approach because we don't want the venous insertion to interfere with the chest compression or defibrillation. So for this approach, the patient is usually is being placed in the supine position, and then we look for the femoral artery pulse. So this pulse we can palpate below the inguinal ligament, as we know that the inguinal ligament connect the pubic bone to the anterior superior iliac spine, right? So in the midway of this inguinal ligament, beneath it is the femoral artery pulse. Try to feel the pulse, and then medial to it is the about 1 cm medial to it is the femoral vein, and then insert the needle about 45-degree angle, and push it slowly towards the umbilical. Okay, so this is the summary for all of the locations: internal jugular, subclavian, femoral, and that's all. Thank you. Any question?
I have a question for central
Yes.
venous central line, yang which route is much more preferable between the IVC, subclavian and the femoral, and which one is the most easiest and safest?
From what I read, it is either internal jugular or subclavian. Mm. Mm. But I'm not sure in clinical practice how we usually do it. Maybe doctor can confirm that. Hello, hello. Hello, doctor.
No, kejap. Ada patient. Kejap.
Okay,
Cuba
tak apa, tak apa.
tengok. Kejap.
Tak apa, tak apa.
Okay,
Ada satu soalan
so
lagi,
tadi
Kak.
okay. So
Okay.
what is the method yang kita guna
Ya,
tadi?
betul.
I rasa tak mention that method untuk insertion.
Oh, Saldinger teknik ke?
Okay, good. Surgery technique.
Saldinger.
Okay, and then cuma kan, actually the most common yang kita guna is in pediatric. Which side and the most common?
Which side? From what I read is either IDV ataupun subclavian, but
Okay. Actually kita tak buat, kita jarang buat subclavian. It's very difficult tau buat subclavian. Bukan difficult macam mana. Biasa subclavian kita buat kat OT. Biasa plastik ataupun NS lah yang buat. Kat bedside by pediatrician biasanya majority kan kita buat femoral. Because that's the easiest.
Femoral.
Okay, femoral. Second easy is IJC. Tapi in neonates IJC ni macam susah gila because they've got short neck. So what ada alternative yang kita boleh buat selain daripada ni? Kita buat PICC lah kan? Pernah dengar PICC kan? Okay, so biasanya kalau in neonates kita akan buat PICC. Kecuali the problem with PICC, you cannot use PICC for resuscitation. Okay, so ada umbilical kan, then you ada PICC. PICC ni masuk from peripheral sampai center, it's a central line lah. Tapi problem PICC, you tak boleh guna untuk resus sebab dia small, very small caliber. Okay, so untuk resuscitation, you guna femoral atau IJC lah. Okay, good, next. 10 minit, ni lebih 10 minit ni. Syat. Okay, jom.
Kenapa? How to, okay dah.
Assalamualaikum. Can you guys see my slide?
Not yet.
We see.
Okay. Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Umi Ifah, and I will be presenting about the endotracheal ET intubation. Endotracheal intubation is a medical procedure in which a tube will be inserted into the trachea through the mouth or nose of the patient to assist respiration. Okay, for the indication and contraindication, it is indicated in patients with unstable airway, for example, in infection, anatomical, and also neurological dysfunction. Infection due to upper airway infection, such as croup epiglottitis. For the anatomical, in patients with congenital syndromes accompanied by microgracia and also micropnetia, as seen in a few syndromes such as Beckwith-Wiedemann syndrome and also Pierre-Robin syndrome. For the neurological, it is indicated in patients with bilateral vocal paralysis. It is also indicated in patients with impaired gas exchange that can present with hypoxia or hypercarbia. Also indicated in patients with lower airway obstruction, as seen in asthma and also bronchiolitis. It is also indicated to patients with a reduction of mechanical load, as seen in shock state or in some patients with cardiovascular disease. For the contraindication, the first one is severe airway trauma or obstruction that does not allow safe placement of the tube, severe cervical spine injury that requires complete immobilization, and also in patients with Mallampati score of 3 or 4 that suggests potentially difficult intubation. So the anatomical differences between pediatric and adult airways, for the children, they have larger tongue, shorter mandible, shorter and narrower hypopharynx, higher larynx. The epiglottis is more U-shaped and also funnel-shaped airway. As you can see here, it is funnel-shaped, the tongue is bigger, and also this is the picture of comparison between the newborn epiglottis and also the adult one. For the preparation for the intubation, If it's not an emergency situation, an informed consent should be obtained from the parents. The equipment to be used should be functional, adequate personnel, and also the heart rate, respiratory rate, blood pressure, oxygen, and also carbon dioxide saturation should be monitored throughout the procedure. As for the equipment, the equipment include mask and ambu bag for ventilation, endotracheal tube. It can be cuffed and also uncuffed. For the cuff one, there is an inflatable balloon at the distal end of the tube. The cuff one is indicated for patient that has concern for aspiration. So when this is inflated, it will be sealed to the tracheal wall, and then can prevent aspiration of the gastric content or anything. And then there is stylet. Stylet is used to adjust the curve of the tube to avoid any trauma to the patient. Laryngoscope, it has two shapes. It can be straight and also curved, and they come in many sizes, and it is indicated according to the age of the patient. Colorimetric and tidal carbon dioxide device, capnography monitor, both are used to monitor the carbon dioxide concentration and partial pressure. As for the tape is used to secure the position of the tube. Syringe is used to inflate the cuff endotracheal tube. And nasogastric or orogastric tube is used for gastric decompression for when to protect the patient against gastric content aspiration. And then pre-oxygenation phase. In this phase, the patient will be given high flow oxygen for about 3 to 5 minutes. And this will allow the clinician enough time to intubate successfully. So first, we will position the child in sniffing position. This is where the neck is slightly extended, but make sure not to hyperextend or underextend. For the ventilation technique, it can be 1% ventilation technique or 2% ventilation technique. For the 1% ventilation technique, he will use the left hand to hold the mask to the face of the patient, while the other hand do the pumping. Here, for the holding of the mask, we use the CE technique, in which the thumb and the index finger will form the shape of C while holding the mask, while the other 3 fingers will form the shape of E when holding the under chin. Okay. For the 2% ventilation technique, one person will use both of his hands to hold the mask to the face of the patient, while the other person will do the pumping of oxygen. For the pre-medication, it is to reduce and also eliminate the pain, the discomfort, and also the physiological responses to the intubation by the administration of analgesia, sedation, muscle relaxant, and also vasolytic agent. Now is the intubation. For the intubation, first thing first, the clinician will stand behind the head of the patient. This is where the clinician will stand. And then to open the mouth, we will use hand rather than using the blade of the laryngoscope. So when the mouth is open, we will insert the laryngoscope. We will insert at the right side of the mouth of the patient and push aside the tongue. And then we will look for epiglottis. There is it, and we will elevate it to expose the vocal cord. And then ET tube will be inserted into the airway along with the stylet. And then the laryngoscope and the stylet will be removed. And then we will tape the tape to secure the position. And lastly, the oxygen will be supplied through the mechanical ventilator or oxygen bag. And these are the steps on how to intubate. For the cuff tube, we will inflate the cuff after removing the bed and the stylet. Now, monitoring after the intubation include ultrasonography to view the passage of the tube that enters either to the trachea or the esophagus. Auscultation to make sure that no air movement should occur over the stomach, because this can indicate the intubation of the esophagus, and capnography to observe the carbon dioxide concentration. The complications that may occur during the intubation include vocal cord injury, aspiration of the gastric contents, severe hypoxemia, laryngeal edema, pneumothorax, but it's quite rare, ventilator-associated pneumonia, intubation of esophagus, and also tooth avulsion. For the practice recommendation, rapid sequence intubation, RSI, is the preferred method of endotracheal intubation in the emergency department. In this procedure, we will administer induction and also paralysis medication to the patient. It is important in patients that have not fasted because they are at greater risk of vomiting and also aspiration. And RSI is not indicated in patient who is unconscious and apneic. These are the list of the medication that may be introduced to the patient along with the indication and also doses. These are the references. Is there any question?
Okay, great. Okay, good. So actually, I just baru intubate pagi. Tadi baru intubate seorang patient. So it's a good revision. Ada questions? Okay, last time kan we were using Nelson. Apa dia? Ada soalan.
Soalan. How to know whether the EP intubation is inside the lung or the esophagus?
By viewing after monitoring after intubation, you can see using the ultrasound to see the passage of the tube.
Okay.
Okay, you ada dua cara lah. Actually, it's direct or indirect. Okay, you ada direct and indirect. Direct is by direct visualization. So you kena tengok the vocal cord. Okay, orang intubate tu je yang boleh tahu. Indirect is by auscultation, by chest rise. You boleh tengok vapor kan, presence of vapor dekat tube. And then X-ray. Okay, last kali X-ray lah. X-ray is the gold standard lah. You buat X-ray nampak kat mana ETT tu ended. Okay. And then there's satu you kena aware, there are nasal intubation, oral intubation. Previously we used nasal. Until recently, I think since 2010 macam tu baru kita start guna oral intubation. Because nasal intubation is easier, tapi you need to use crocodile clamp lah. You kena ada tool. Tapi kalau oral intubation just tube je guna oral. Cuma nasal ni kelebihan dia lagi secure. Dia tak gerak-gerak. Kalau oral ni dia easy to dislodge. Okay lah. Okay, next. Ada lagi soalan? Ada soalan? Tak ada. Okay, good. Okay, next.
Okay, Bismillah. Do you see my screen right now? Yes, okay. Okay, so inshallah, I will proceed with the presentation on how we want to measure the height, weight, and the head circumference. Okay, so without further ado, let's start. Okay, so first of all, why do we need to measure that perimeters? It is basically for the basis of our clinical assessment. We want to assess about the growth of the child, whether it is developed or in the schedule, or up to exceed the schedule. And also the measurement is also important for to calculating the BMI in the children. Okay, so if we see if there any underdevelopment or the height or the weight is not enough for the normal population, further assessment need to be done, and we need to assess what might be the underlying causes. Okay, so we start for the height. Okay, for the height for children, or for children below 2 years or equal to years, which is the neonates, infant, and toddlers. Okay, neonate is below 28 days, right? Okay, so we need to measure the not the height but the length, because in neonates it can extend. Right. So we need to use the measuring board, and for the techniques, it is recommended to for there are two-person involved, because one need to maintain the position of the baby in the supine position, and the other one is to measure the length of the baby, and the measurement is need to be recorded in the nearest 0.1 cm, and okay, it need to be recorded in the growth chart. Okay, next is for the height, which is for the children more than 2 years. The equipment needed is the stadiometer, stadio meaning the standing. So we need to measure the height of the children in standing position. So what do we need to ensure is the children is not wearing any footwear, and 3 measurement must be taken, and we need to calculate the average, so that to ensure the highest accuracy, and plot the result on the growth chart. Okay, next is for measuring the weight. Okay, for children for 2 years and below, we need to use the calibrated weighing scale, because calibrated is we need to ensure that the pointer is at the zero, and okay, to ensure the highest accuracy, we need to ensure that the baby should wear minimal clothing, and minimal clothing, which the baby might wear diapers only. And the measurement should be recorded to the nearest 0.1 kilogram, and we need to chart it on the growth chart. Okay, next for the children above 2 years old, we can use the standing weighing scale, and to measure the to measure the uh, to measure the weight, we need to ensure the minimal clothing for the child, which appropriate, and the measurement is recorded to the nearest 0.1 kilogram, and we need to plot the measurement on the standardized growth chart. Okay, next is the occipitofrontal circumference, or OFC. It is also called as the head circumference, and it is measured up to the children to the 3 years old, because at this age, the head growth is the highest or greatest. And the equipment used is the flexible measuring tape. And how how to execute this procedure, how to measure the OFC, it is by using the flexible measuring tape, and measure the maximum diameter which pass the supraorbital ridge, and at the front, and to the occiput at the back. So repeat the measurement 3 times, and we take the highest in this procedure. And the measurement is also recorded to the nearest 0.1 centimeter. And after we we get the measurement, we plot it onto the standardized growth chart. Okay, so this is the diagram that display that show where is the occiput and the supraorbital ridge. And for macrocephaly, it is the more than 2 standard deviation above mean, while the microcephaly is 2 standard deviation below mean. What is the meaning of above and below 2 standard deviation? Basically, if you still remember in the statistic, we learned that this is the normal graph chart, and this is the mean, the mu, this is the mean, and this is the sigma, or this is the symbol for standard deviation. Basically, the 2 standard deviation above or below mean indicates 95% of the population, 95% of the samples. So for head circumference, which is two standard deviation above or below the mean, it indicate this region, which is 2.5 above this and 2.5 below. So this region indicate macrocephaly. This region indicate microcephaly. Okay, so what is we need to take in our mind. Okay, the OFC or head circumference can be affected by the thick hair. If the baby has thick hair, it might obscure the real measurement. And if the baby also have the cranial bone deformation or hyperostosis. Next, head and weight should be plotted simultaneously in the case of normal centile of head circumference, but with disproportionate body growth. And head circumference also need to be done in the older children with abnormal height or weight. So that's all for the head circumference. Okay, this is the growth chart for the boys. Okay, for the boys, and this is for the girls, and this is for the preterm. You can see this, it contain weight, the length, the head circumference, and the gestational age. For preterm, it is the babies that doesn't enough 38 weeks, if I'm not mistaken, in the womb. Okay, so this is the head circumference graph for male, and this is for the female. Okay, I think that's all. This is my sources, and thank you. Do you have any question?
I have a question. For the growth chart tu kan, to include semua ke height, weight dengan OFC or the only OFC ke macam mana?
Is it this one you mentioned?
The growth chart. This one kan?
Okay, for this one, the image is not too clear, but I think it is only include the length only.
Oh, so different parameters, different growth chart lah macam tu. Oh, okay. Understood. Thank you.
But I didn't sure for the clinical practice today, but because I already searched the growth chart for from different from the web, but I didn't found the latest or the one that include all of the measurement. Okay, if you don't have any question, I think I will pass to the next presenter. Thank you.
Jap. Actually there's a, so you present 3 je kan? Growth chart.
Yes, doctor.
Okay. Actually there's a lot more growth chart lah there. You tak present length for weight for length kan? Weight for length. Tak ada kan? You length for age, weight for age dengan head circumference kan?
Yes, doctor.
Okay. Okay, when you talk about growth chart kan, we have to use the standard growth chart lah, guna WHO growth chart. Okay. Lepas tu, it's important to plot as many growth chart yang related. Especially macam weight for length is very important. Sebab kalau you nak tahu, growth chart ni is a tool untuk so kalau you nak tahu patient ni dia ada acute malnutrition ke, dia ada chronic malnutrition ke, ataupun you nak tahu this is obese ke, underweight ke, you have to use the correct growth chart. Okay. So definitely the most important is actually length for age. Yang tu the most important. Length for age. And then you kena second is weight for length. and then weight for age, and lastly height circumference. Okay, and each growth chart tu dia will point you what is the problem. Okay, contoh lah kalau patient ni dia dekat weight for length, weight for length dia. Okay, for that particular length, weight dia rendah kan. Contoh weight for length dia Z-score -2 and below. So you tahu the problem with this child is actually acute. This is acute malnutrition. Okay. Tapi kalau dia punya length for age dia dah memang less than 2 standard deviation, then this is a chronic problem. Faham tak? Sebab you didn't expect acute malnutrition cause will affect your punya height. Faham kan? No. So you have to read all the growth chart, plot all the growth chart, and then interpret them together lah in the same setting. Don't separate them. And then kalau growth chart ni something very important sebenarnya. Then don't use the growth chart yang ada kat buku biru tau. It's useless lah. Use a proper growth chart. Guna WHO punya growth chart kalau boleh. Less than 2 years old, less than 5 years old, guna WHO growth chart. More than that, guna CDC punya growth chart. Ada 2 years to 20 years old. Preterm you have to correct for how long? For until what age you have to correct for the prematurity? Ashraf,
Sorry, doctor. I don't know.
Up to 2 years, okay? 2 years. So contoh kalau baby ni prem 20 week, 30 weeks kan. So dia delayed, dia early by berapa? By 2 months kan. Then you kena plot, contoh sekarang ni dia datang umur dia 2 tahun. So you kena plot dekat setahun 8 bulan, setahun 10 bulan. Bukan 2 tahun. Faham? Tapi kalau contoh dia datang umur dia 3 tahun, then you plot dekat 3 tahun. After 2 years, you should not correct for the prematurity. So plot ikut chronological age. So you kena tahu what is chronological age, what is gestational age, what is bone age. Okay, faham? Okay. Okay, I suggest you guys baca. Okay, make sure balik ni you guys baca WHO growth module for growth training. Contoh just type WHO module for growth assessment macam tu lah. And then you read on that. Module F, baca module F ke module G? Module F. How to plot and how to interpret growth chart. Because this is very important lah. So definitely akan masuk exam. And kalau you tak boleh interpret growth chart, macam you nak diagnose stunted, you nak diagnose obesity, you nak diagnose short stature. Okay, these are all diagnoses based on growth chart. Okay, nak diagnose constitutional delay. Tak ada kan? Okay lah, okay. Okay, next presentation. Faham kan? Ke tak faham? Faham? Okay kan?
Faham.
Oh ya, I memang kena rushing lah sikit. Pukul 2 suku ada CME pula. Okay. You guys datang sini balik bila? Face to face. End of ni kan? End of December kan?
End of December.
Wah, lambat lah. Tak pelah. Okay lah. Okay, continue.
Semua orang boleh dengar ke? Clear kan? Hello?
Boleh.
Okay. Okay, so Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Najih Zulfa and I will be sharing about nasogastric tube insertion. So first of all, what is the definition of nasogastric tube? It is a small tube that is passed through the nose into the stomach. And the indications for nasogastric tube insertion is to provide enteral feeding or to deliver medications to a child that cannot eat orally, maybe due to known or suspected risk of aspiration, depressed mental status, poor pharyngeal muscle control, and as well for endotracheal intubation. It is also indicated in patients to aspirate gastric secretions or air in the patients who require continuous drainage of gastric secretions, required lavage of stomach contents, which is needed in poisoning cases, and to aspirate air from the stomach. And it is also done for the following reasons, such as decompression of gastrointestinal tract, and to assess and treat for upper gastrointestinal bleeding. Next, what we have to prepare before doing the nasogastric tube insertion. Firstly, we have to get the consent, which is informed verbal consent must be obtained prior to the procedure and must be documented in the healthcare record. And secondly, we have to identify the patient's name and procedure verification, and we have to note on the patient's allergy and do adverse reaction check. And next is we must do the procedure in treatment room. It is because we have to preserve the child's bed space as a safe environment, which is free from painful or unpleasant procedures. Next is observation, in which we have to undertake the patient's observations pre and post the insertion of the gastric tube. What we have to take note of is the heart rate, respiratory rate, and they must be documented. So the equipment needed for the nasogastric tube insertion. Firstly, of course, we must have the nasogastric tube. We should also have disposable glove, water or lubricant, which is to lubricate the tip of the tube, large syringe, which is to obtain and aspirate from the nasogastric tube, and for a pH testing strip, which is to assess the pH of the aspirate. Dressing is also needed to secure the nasogastric tube, and the others are like disposable bowl, paper towels, and glass of water for the patient. This is only if the patient is allowed to swallow. And also, in some cases, they might need local anesthetic spray to numb the oropharynx. So this is the guide to the gastric tube size, just like in the table. However, special consideration must be given for the tube size selection in children with developmental or physical delay, and in patients who are very small for their age, we have to indicate a smaller tube to be used. The positioning of the patient. Firstly, for an infant, we have to wrap the infant in the sheet or cuddly, just like in the diagram, and the patient must be in the supine position. And for a toddler, we can ask the parents or the staff to hold the child in a seated position, and the child should not lean forward nor having their neck extended. And for distraction therapy can also be used to help a young child to cope to develop coping strategies, in which we can have a carer to carry this out. The carer can use bubbles or action toys to distract the child, and if available, we can ask for a child life therapist to be involved in the procedure. So the procedure starts with the first step is to measure the tube from the tip of the nose to the bottom of the earlobe, and then to the observed midpoint between the Zephyr process and the umbilicus, as you can see in the pictures. And the length of insertion should be noted in the child's clinical record. Secondly, we have to lubricate the end of the tube with water or water-based lubricant. This is to avoid irritation to the esophagus. The third step is to examine the nostrils for patency to determine which side is the best for insertion. And if it is age appropriate, we can ask the patient if they have any problems with either side of their nose, because sinusitis can increase irritation from the nasogastric tube. In younger children, we can just gently occlude each nostril separately and insert the tube in the nostril with the best airflow. Next step is to gently insert one nostril into one nostril and advance the tube posteriorly. Then advance to the nasopharynx, allowing the tip of the tube to seek its own passage into the esophagus until it reaches the stomach, which we can see by seeing the measured marking is reached. Okay, the fifth step is if it is age appropriate, we can instruct or encourage the patient to swallow, either using a dummy or oral sucrose, and advance the tube as the patient swallows. For infants or child with intact gag reflex, we can give them small sip of water so that they can swallow. So because it can enhance the passage of the tube into the esophagus. Sixth step is to observe the infants or child for any excessive gagging coughing, wheezing, apnea, or color change during the placement, because this may indicate the passage of the tube into the trachea. And if it is suspected, we have to withdraw the tube and readvance once the patient is stable. Next step is while advancing the tube, if there is any resistance, we have to withdraw the tube 1 to 2 centimeter and rotate it slowly with downward advancement directed towards the closest ear, and we should never force the nasogastric tube. Okay, so how to confirm the placement? Firstly, we have to note the external length of the tube at the nostril, and then we can gently aspirate a small quantity of gastric fluid with the smallest practicable syringe size, usually 2.5 ml syringe. And then we have to check the pH of the aspirate on the pH indicator paper. So usually the aspirate stomach contents usually have the pH of 1.0 to 4.0, and it is considered safe because there is no other body fluid that have the pH with this range. However, in patients who is on antacid treatment or acid suppressing medication, this range may be significantly altered. And then in the third step, to confirm placement, we have to ensure the external length of the tube remains unchanged from the step 1. And then we have to ensure the remainder of the tube with tape, just like in the picture at the right. And next, before starting feeding the patients with at risk, we have to consider doing an X-ray because pH testing can give false negative. And then the at-risk patients are patients who are on gastric acid pump inhibitors, gastric pump continuous feeds, and others. And after the procedure, we have to document in which firstly we have to comfort the infant or child, and then dispose all the equipment according to local standards. And then we have to observe. We have to undertake the patient's observation, including the heart rate, respiratory rate, respiratory and oxygen saturations. And we have to document these observations onto the chart. And we should also document the procedure done to the patients in the patient's healthcare record, such as noting the tube type, size, date, expiry amount, pH, and color. And we have to notify any problem or abnormalities to the relevant medical officer. So this is the algorithm for the nasogastric tube insertion. So is there any question? I have a video to show. Okay, this is the process. Wait, jump next. All right, can you see the video?
Yes, we can see it.
All right.
Are you ready for tube? Okay. Okay. Let's go right here. Let's press that in place so it can get nice and well secured. Oh, good. That's a great job with it. Thank you. All right. Now let's measure and see how long we're going to put the tube in. Okay. Just get my hand. It's okay. You're suspicious, aren't you? Okay. Yeah, we got to put your feet down so I can see what I'm doing. Okay. All right. Mama, can you hold his hand for me? There we go. To the breastbone. Where's your belly button? Okay. All right. Oh my goodness sakes. You're getting suspicious now, aren't you? Okay. Let's get you swaddled.
Okay, Mama, can you hold his hands for me? Stay right there. There we go. Just like that. It's perfect. Okay, here we go. Yeah, it's all right. Okay, can you hold on to the tube for me? We're all done. We just need to get some tape on there. Pacifier tape too. Oh no! I'm so sorry. I shot you with water.
Can I pick him up?
Yes, you can pick him up. We're gonna need to check the fluid in his stomach, but yeah. Has he just been fed?
No.
Okay. Okay. Let me check the pH on this and see what we get here. Okay, we have a pH that is acidic. So our 2 is in. NG2.
All right, that is all for my presentation. Is there any question?
I got this aku.
Tadi dia impian lah.
Okay, Assalamualaikum. Rice tube okay, ada soalan?
Tak takut lah tu.
Be careful lah. One of the most common complication is actually tracheal punya insertion lah. So it's happened to me once. I masuk rice tube. Actually sebab nurses semua takut nak masuk rice tube. Patient tu platelet very low, patient leukemia. So they asked me to insert lah, especially suruh registrar, the most senior masuk lah. So I pun confident lah masuk. So I pun masuk rice tube. And then okay lah, baby tu okay semua. Tak guna lagi, gunalah letak susu sikit kot. Tapi okay je. Oh tak, lepas tu buat x-ray. Bila buat x-ray, tengok rice tube tu dalam lung. Dalam right lung. Dekat USM. Masalahnya budak tu okay je. Tapi be careful lah, because kalau you bagi something and then dia expect the lung, then it'll be very dangerous. Tu lah.
Maksudnya masa doktor dia punya pH berapa doktor?
Itulah ya. Sometimes memang actually what you present is something yang standard lah, gold standard, ideal situation. Tapi actually in real life kita tak measure pH, aspirate pH, kita tak measure. We confirm the placement is by X-ray. You aspirate and then you dapat some fluid ke benda, then you buang je, you tak hantar pun untuk pH.
Faham.
Tapi you confirm by X-ray. Yang tu in either situation kita buat lah, tapi realistiknya kita tak buat. Okay. Tapi kalau exam tanya, you buatlah salah satu method untuk confirm placement is check pH. Okay, next.
Doktor, tapi kan NG tube ni boleh guna juga untuk intubation.
Tak boleh, mana boleh intubate guna NG tube?
Yang doktor kata tadi tu nasal intubation bukan?
Bukan, nasal tube guna ETT tube, ETT yang sama tapi masuk ke hidung. Yang present tadi masuk ikut mulut kan? Tu oral intubation. This is nasal intubation. You masuk ikut hidung, masuk ikut lubang hidung tu. And then you masuk crocodile clamp ikut mulut. You nampak je tube kan? So you guide. You tolak je ke bawah guna crocodile clamp. Tu nasal tubing, nasal intubation. Yang bagus dengan nasal intubation, you tak payah ikat-ikat pun. Sebab hidung you dah keep it secure. Dia takkan gerak-gerak. Kalau oral intubation, you intubate oral and then you kena ikat kat mulut semua tu. Kena secure. Tapi guna ETT, guna endotracheal tube, bukan je guna RAS tube. Ataupun, mana boleh RAS tube intubate. Unless in some emergency, especially patient yang difficult intubation kan. Contoh you dah intubate and then they dislodge. Sometimes what you can do is, contoh dia dah dislodge, contoh patient struggling, dia nak dislodge kan, you takut dislodge, you boleh masuk RICE tube untuk guide. You masuk RICE tube through the ETT, and then you buang ETT lama tu, you masuk ETT baru. Guna RICE tu. Macam Salinger teknik tu lah. Guide wire, dia akan act macam guide wire. Faham kan? So kita guna RICE tube sebagai guide wire. Tapi that is not standard practice and should not be done unless in emergency. Faham tak? Okay, next.
Can you guys see my slide?
Yes.
So Assalamualaikum, I am Syazwani binti Marmeni and I will be presenting about the lumbar puncture. So lumbar puncture is a procedure to obtain the cerebrospinal fluid from the subarachnoid space. So the indication for the lumbar puncture if the patient is suspected with CNS infection such as meningitis or encephalitis, or if there is suspected subarachnoid hemorrhage, and also the lumbar puncture can also be used to remove the cerebrospinal fluid from the patient with idiopathic intracranial hypertension. And lumbar puncture also can be used to administer chemotherapy intrathecal therapy for oncology patients, and also for the diagnosis of neurologic conditions such as the Guillain-Barré syndrome and also the multiple sclerosis. And in selected patient, it is used to investigate the pediatric metabolic disorder. So for the contraindication, so it is contraindicated to do lumbar puncture in patient with increased intracranial pressure. So we can see this increased intracranial pressure from the signs and symptoms such as the bradycardia, irregular respiration, raised blood pressure, and papilledema. So CT scan or MR brain should be performed before the lumbar puncture to identify the cerebral edema or the space occupying lesion or the obstructive hydrocephalus. So this lumbar puncture is also contraindicated in patients with respiratory distress because children with respiratory distress, they may become hypoxemic or apneic, especially in the lateral recumbent position during the lumbar puncture. Next, it is contraindicated for the patient with bleeding tendency if the platelet count is less than 50,000 microliter and the patient have prolonged PT or APTT. So it is also contraindicated in to do the lumbar puncture at the skin infection. If there is a skin infection over the side of the lumbar puncture, because there might be other infection can be induced. So if the patient also is hemodynamically unstable, it is contraindicated to do the lumbar puncture. So we need to stabilize the patient before do the lumbar puncture. Take note that the antimicrobial therapy should not be delayed if the patient cannot do the lumbar puncture. So next, for the preparation for the lumbar puncture, first we need to evaluate the patient. So evaluate whether the patient is fit for the procedure. So identify any condition that contraindicated for the lumbar puncture. Next, give the patient counseling. So give a clear explanation of the urgent indication and details of the procedure, what will happen during the procedure, and also the complication of the procedure. Next, prepare the equipment. So the equipment include the sterile glove, traps, dressing, the 4 collection tubes, antiseptic solution, the spinal needle with stylet, So we use a 20 to 22 gauge size needle, and the length is 1.5 inches for patient less than 2 years, or patient between 2 and 12 years, we use the 2.5 inches length, and for patient over 12 years, we use the 33.5 inches length. So next is the lidocaine, the sterile syringe, the manometers, the gauzes, and the bandage, and the resuscitation equipment. So this is the equipment. This is the commercial tray for the lumbar puncture. So it has the three-way stopcock to use with the manometer, the lumbar puncture needle, the gauze pad, the syringe, the lidocaine, the marking pen to mark the lumbar puncture site, and this 4 specimen vials, the drapes, and also the antiseptic solution. So this is a size. So this I want to show the spinal needle and the stylet. So the stylet need to be firmly put inside the spinal needle. So next, for the positioning, it is important for a careful positioning because we need to identify the landmark for the lumbar puncture. So the patient can be positioned either in the lateral recumbent position or the seated position with the neck and legs flexed. So in lateral recumbent, the assistant can help the children to draw the knees upward and neck and flex the neck. Meanwhile, for the sitting position, the assistant can grab one of the infant arms and also the one of the legs in each hand while supporting the neck to prevent excessive flexion of the neck. So for all the children, all the children should be asked to sit with their legs hanging over the edge of the examining table, and they can be flexed over a pillow with the elbow resting on their knees. So during this positioning, an assistant should maintain the alignment during the procedure, even in cooperated children. So regardless of any position chosen, it is important to make sure that the patient's shoulder and hips are straight and perpendicular to the bedside. It is important to keep the patient's shoulder and hips are straight and perpendicular to the examining table in order to maintain the spinal alignment without the rotation. So for identifying the landmark for the lumbar puncture, we need to first locate the posterior superior iliac crest and then draw the imaginary line that connects the crest. So the intersection between the imaginary line and the spine, it is approximately at the L4. So that is the site for the lumbar puncture. It is at the interspinal space between the L3 and L4. So next, for the procedure. So after getting the written consent and prepare the equipment, we can give sedation to the patient for safe performance of the lumbar puncture and apply the local anesthetic 30 to 40 minutes before the procedure. And next, position the patients either in the lateral recumbent or sitting position and identify the puncture site. So according to PITS protocol, the puncture site is between L3 and L4 lumbar, L3 and L4 vertebra. Next, clean the puncture site in a circular motion and then expand the circular motion circumference. And then place the drape underneath the patient and over the drape that have the eye hole over the patient to cover the above and below of the vertebral bodies. Next, insert the spinal needle perpendicular to the puncture site, pointing towards the umbilicus, and advance the needle slowly until you feel some give, or it also sometimes because there is a change in resistance when the needle enter the subarachnoid space. Then remove the stylet and look out for the CFS flowing. So if there's cerebrospinal fluid is flowing out, so that means that the needle is in the correct space. Next, measure the opening pressure measure the opening pressure by connecting the needle to the CFS manometer, and then collect the CSF in the designated bottle. So it's usually 1 milliliter per bottle. So we have 4 bottles just now. So in each bottle, it's approximately 1 ml. Next, gently withdraw the needle and clean the puncture site and apply the opsite spray on the puncture site and cover it with gauze and bandage. Next, ensure the patient lies supine for the next 4 to 6 hours and continue to monitor the patient until he or she recovers from the sedation. So in doing the procedure, there might be a problem. So troubleshooting is needed. So the first problem that might happen is the bony resistance. So bony resistance can happen due to puncture over the posterior spinous process. So we can overcome this with withdrawing the needle to the subcutaneous tissue and confirming the spine position. So confirm that it is not rotated and palpate the spine again to make sure that the puncture line is in the middle line, in the midline. Next, the bony resistance can also occur due to puncture over the inferior spinous process. So we need to reposition the child to ensure there is an adequate flexion, and then redirect the spinal needle more sharply cathephrate, meaning upward. Next, the next problem that might happen is poor flow of this FS. So we can, there is some techniques that can improve the flow of the CFS, such as the rotate the spinal degree by 90 degrees until we can see the flow of the CFS. Next, replacing the stylet and advancing the needle slightly, or we can attempt at a new site with a new needle. So for traumatic puncture, it can occur when the spinal needle strikes the venous plexus and circle the spinal cord when it go through the subarachnoid space. So if the spinal needle is filled with a bloody fluid clots in the hub of the CFS circle, we need to remove the spinal needle, and then we can reattempt the procedure at new site with the new needle. So this is the post-procedural complication. So the most common minor complication that is reported is the post-spinal headache and the back pain. For the others, it is a major complication, but it's rare, such as the cerebral herniation, infection, spinal hematoma, and epidermoid tumor. So for post-spinal headache, we can use smallest possible or a traumatic needle to reduce the leakage of cerebrospinal fluid to lessen the post-spinal headache. And the back pain usually resolve within a few days. For the cerebral herniation, it is the most serious complication, and it usually occur when the lumbar puncture is performed in patients with increased intracranial pressure. So infection, such as the bacterial meningitis or epidural abscess, can be induced if the lumbar puncture is performed in patient with skin infection at the puncture site. So spinal hematoma usually occurs in patients with uncorrected bleeding disorder, and epidermoid tumor is a rare complication that may become evident years after the procedure is performed. So this is my reference. That's all from me.
Okay lah, good. Very important procedure. Okay, any questions? Any questions? Okay, remember LP is a very important procedure. Even though in our culture it's a taboo, tapi you have to understand this is very important lah. Okay, you need to have a very good counseling skill. And it is a requirement lah untuk all doctors, houseman ke MO, to be able to understand and to be able to get consent, to take consent from parents into LP. So you guys should be able to explain to parents how the procedure done, the complication, the method lah, semua tu lah. Okay, ada soalan?
Tak ada.
Kita ada berapa orang lagi?
Lagi 2 tak?
2. Okay, boleh tak kalau saya nak berhenti semayang kejap je? Dalam
boleh.
15 minit ke? Boleh?
Kita sambung pukul 2 yang tak?
Pukul 2. Okay, sebab ada orang nak semayang. Alah, saya ikut lah. Okay.
Okay.
Thanks. Assalamualaikum. Assalamualaikum. Dah ada ke semua?
Lagi seorang doktor.
Lagi seorang?
Okay.
Ke awak seorang?
Tak, lagi seorang.
Okay, lagi seorang. Tak apa, kita start lah terus. Saya 2 suku saya ada.
Okay dah cukup dah.
Okay.
Dah cukup dah doktor.
Kita start lah. Okay.
Sekejap. Okay, so Assalamualaikum and good afternoon. My name is Muhammad Al-Hakim and I'm going to present about chest physiotherapy and suction. Okay, first is the chest physiotherapy is a therapy of mobilizing pulmonary secretion, mucus or any secretion. And it consists of percussion, vibration and postural drainage. Postural drainage is in the conjunction of the percussion and vibration. And it is followed by productive cough or suctioning of a patient. Okay, next is the indication is to whom cough is insufficient to clear thick, tenacious or localized secretion, for example, cystic fibrosis, bronchiectasis, lung abscess, pneumonia. And contraindication to the patient that we can't do this chest physiotherapy is increased ICP, intracranial pressure, active hemoptysis, recent spinal injury, and or surgery, rib fracture, and flail chest. Okay, so before we did the physiotherapy procedure, okay, first we need to know the vital sign like heart rate, respiratory rate, oxygen saturation, any contraindication to this patient, detailed physical examination chest, and X-ray to look for any contraindication. Okay, next is the technique. Okay, first is the percussion or cupping. Okay, it's a rhythmically clapping on the chest wall over the area being drained to force secretion into the larger airways. Okay, so the photo on the right up is the correct hand position for chest percussion, and we also can use the tools like the cup there, and we do like the woman does, but not with 2 hands. In pediatric, we use it 1 hand, and it not too fast but slowly and produce hollow sound and should not be painful for the secretion to get into the larger airways to expectorate. Okay, next is vibration. Gentle shaking pressure applied to the chest wall to to move secretion into large airways. Which the how it done is place flat hand firmly against the chest wall, vibrate the chest wall like the woman does as the patient exhales slowly through his lips. We did the vibration when the patient is exhale and encourage patient to cough and expectorate. And we did like the woman, but not too hard on pediatrics, but enough pressure for them. Okay, next is the postural drainage. It is the different position assumed to facilitate the drainage of secretion from bronchial airways. Gravity helps to move the secretion to trachea. And this position, and we did the percussion and vibration at the lung. And here's the position. The first one is the anterior segment of upper lobes. Second one on the right is the posterior segment of upper lobes. And we did on both sides with both of the percussion and vibration. So the third one is lateral base of upper lobe and lower lobe. Okay, so this is how the chest physiotherapy be done. Okay, next is the suction. Suction is expirating secretion through a catheter connected to a suction machine or wall outlet. First, before the procedure, keep all the suction kit in sterile and hygiene, head at 30 degree. And during the suction the suction must not longer than 5 to 10 seconds. And the post procedure try to stimulate the cuff. And the catheter size different from the age, of course, like in the table. And I'm going to show you the video, simple video. Sorry. Okay. Okay, so the catheter should be 1/3 the size of the opening nair. Nair is the nostril, the nose. Okay, so did you hear the voice of the woman?
No.
No, okay. Very nice. Okay. So of course you keep the tip clean and attach to the suction, the catheter to the suction, and keep your thumb off the thumb pot on the catheter. Yeah. Of course lubricate for the ease passage into the nose. And yeah. Okay, before that we must measure the distance between the nose and the ear for we must to know how deep we want to put the catheter inside. Okay, so before we put the catheter inside the nose, without any suction applied, is keep your thumb off the thumb pot. And yeah. So yeah, then if you want to aspirate the secretion, we put our thumb on the thumb pot, so the suction will begin. And we must do between 5 to 10 seconds. Okay, next is the nasopharyngeal suction. We we do the suction from the into the mouth to the back of the mouth. Okay. So we put on the right or left the patient tongue into the back of the mouth. Okay. Okay, so that is how it done. Okay. The indication for this procedure is sign of respiratory distress, evidence of unable to cough up and expectorate secretion, and obtain sample of secretion for the latest purpose, of course, and prevent infection. Sign and symptoms: abnormal respiratory rate, abnormal breath sound, nasal secretion, gargling during restlessness because because the patient with the secretion that can't expectorate the secretion is they have a difficulty in breathing. They put the most effort to breathe. Yeah. So that's all from me. Thank you. Okay. Any question?
Any questions?
Okay. So
Any
there's
questions?
no.
Tak ada.
Tak ada.
Okay lah. Topik ni macam bosan kak. So anyway. Actually I tak tahu. Dekat Kelantan ada satu center lah. Dia punya sono something. They use macam like ultrasound lah untuk buat ni. Be careful. Okay. Chest physio is contraindicated kalau in acute condition. Okay. Contoh macam patient yang datang dengan ARDS, acute ARDS kan, you tak boleh buat chest physio. Because you will cause further injury lah. You akan cause injury. So biasa chest physio ni kalau patient dah stable, baru you buat chest physio lah. Okay, and chest physio suction is, you have to be very careful juga untuk suction. Because sekarang ni kan COVID kan, so suction tak boleh buat lah. Open suction. So this is aerosol generating procedure. It's dangerous. Okay, next.
Sekejap.
Okay, bismillah. Sekejap. So you can see my screen.
Yes, you can. Yes, you can.
Okay, bismillahirrahmanirrahim. So I will be the last presenter for today. So I will present a long percutaneous line insertion. So let's start with the introduction. It is a sterile procedure of inserting a long line, which is a fine plastic tube, very in length, between 10 to 30 cm long, and it is inserted into one of the vein, usually in the upper or lower limbs, and guided into a large vein just outside the heart, usually in the superior vena cava or in inferior vena cava, and it will remain in the place for a few weeks or months. And it's also same as natal peak insertion, which is preferably inserted central catheter. So for indication, it is to administer parenteral nutrition in very low birth weight infant. It also to administer medication of fluid. It also used in those with difficult peripheral venous access and to those who have who need frequent blood taking in order to avoid repeated needle insertion. For contraindication, it is contradict to be done in a patient who have infection, whether it is systemic or cutaneous infection, especially for cutaneous at the site of insertion, because it can enter our body through the insertion. Other than that, it also contradict in patient who have abnormal clotting factor, because it can cause severe bleeding, and if it need to be done, we need to correct the clotting factor first. Non-thrombus patient also need to be this procedure also need to be avoided. So first, we need to identify the site of insertion. Prior to the procedure, usually we use ultrasound to identify the vein. So the most common site is at the antecubical vein. Usually, we use basilic vein, because this vein it is more it is larger and less tortuous. Usually we prefer at the right side because it's more direct to the central vessel. So for lower limb, we usually the most preferable vein is long saphenous vein at the medial malleolus, and scalp vein also can be used, but it is less preferable. Okay. Insertion length, for before we insert the long line, we need to measure the insertion length. So if we need to, if the long line is at the lower limb, so we measure it from the insertion site to the xiphisternum. So from the insertion site to the groin, and then go up to the xiphisternum. If the insertion at the upper limb, the measurements start from the insertion site to the sternum, around the level second intercostal space. So if it is in using scalp vein, the measurements start from the insertion site to the sternum, same as the upper limb. Okay. So this is the equipments for long line insertion. We have sucrose analgesia, straw gown and glove, tape measure, tunicane, forceps, syringe and needle, sterile scissors, chlorhexidine solution saline, sterile strip, sterile gauze, clear sterile dressing, introducer, and also the important thing is the long line, whether it is it have various types. For example, one of that is PREOXYGENATION or Nutrilin long line. PREOXYGENATION, it have single lumen and usually used in patient who is less than 1 kilogram. For Nutrilin, it has double lumen. Usually used in patient who need double infusion. For example, need parenteral nutrition administration, and also drug infusion. Okay. So for procedure, for initial preparation, we need to prepare all the equipment required. Make sure it is clean, and then we wash our hand using aseptic technique. Identify the patient by checking the handband. Administer the sucrose analgesic to make sure that patient have the adequate pain relief. Okay. So before we putting our sterile gown and glove, we need to wash our hand, and then we clean the skin of the limb using 0.05 chlorhexidine, and then position the limb through a sterile towel, and then allow the skin to dry. After that, we apply the tourniquet. After that, okay, use slight tension to stabilize the vein, and then insert the splitting cannula or introducer with bevel uppermost. So this the position of the bevel, and then when blood flow is seen, the cannula in the cannula, then we begin to insert the long line using forceps until the desired length, and then flushing gently with saline. So if there is resistance or swelling occurs, then we remove the needle and apply pressure to the site to reduce any hematoma occurs. So if the cannula flushes as satisfied, so we remove the cannula by splitting the cannula and lift out the line carefully from the cannula, and then apply stir strip, small gauze, and place transparent dressing. After that, we dispose the waste and document the procedure. Last step is we need to confirm the tip site by X-ray. So this is a video how long line is inserted in neonate.
Neonatal PICC placement is a sterile procedure, and the use of maximum sterile barrier precautions is required.
Can you hear the voice?
Scrub and put on a gown and gloves as you would for any sterile procedure.
Yes,
Prepare the
that's what
desired
slow.
insertion site with antiseptic solution and allow it to dry. The safety of chlorhexidine solutions for premature infants and infants less than 2 months old has not yet been proven by research. Therefore, choice of antiseptic solution may vary according to institution and patient population. When using povidone iodine, remove the povidone iodine after drying to prevent tissue damage, absorption, and thyroid suppression. Flush all lumens of the catheter with a saline-based solution, ensuring that there are no imperfections or breaks in the catheter. When using a catheter with a stylet, pull the stylet back such that its tip is retracted approximately half a centimeter from the catheter tip before trimming the catheter. In accordance with institutional routine and manufacturer recommendation, trim the catheter to your pre-measured length. Some manufacturers provide special trimming devices or guillotines, while others recommend only sharp, sterile scissors to trim the catheter. Peel-away sheath or breakaway needles are common introducer types. Inspect the introducer for imperfections. Many clinicians prefer to flush the introducer to verify patency and prevent blood stasis within the introducer lumen. Puncture the vein with the introducer needle. Observe for blood return. Stop advancing the needle once you observe blood return, lest you puncture the posterior wall of the vein. Withdraw the needle when using a peel-away sheath, then insert the catheter through the introducer to the appropriate pre-measured location. The catheter should advance with ease. And now illustrated on the patient. Puncture the vein with the introducer needle. Observe for blood return and remove the needle from the introducer. Slowly advance the catheter. When the catheter is properly located in the inferior vena cava or superior vena cava, blood should return with ease. Remove the introducer from the skin while holding the catheter with gentle pressure to ensure that the catheter is not retracted. Remove the introducer from the catheter according to the manufacturer's guidelines. When using a stylet, ensure that the catheter has been properly flushed and remove the stylet slowly to prevent damage to the catheter.
Okay. Okay. As I mentioned before, the last step is we need to confirm the tip position. So it can be confirmed on X-ray. Most of the long line is radio opaque, so we do not need contrast. But for if we use PREOXYGENATION long line, we need to use contrast. We also need to on X-ray we should observe if there is loops or buckling of the line. And as I mentioned before, the best position are at the superior vena cava and also in inferior vena cava. And if malposition occur, there is a risk for vein perforation, subsequent extravasation, and worse, if cardiac tamponade occur, if the long line is at the intracardiac position. Okay, for maintenance, the long line, it should be checked, monitored, and documented daily, and minimizing the frequency of your long line use for infusion changes and also for drug injection, and the line should be removed at the earliest opportunity. So this is the how long line is removed.
Remove any neonatal central catheter when it is no longer needed. Neonatal picks should be easy to remove. Cleanse the removal site with the appropriate antiseptic and gently pull the catheter out. Document the length of the catheter that was removed and check the patient's record to verify that the catheter has been removed in its entirety. When the removal of a neonatal pick is difficult, redressing of the catheter and another attempt at removal after a period of several hours, flushing of the catheter, or surgical consultation may be required.
Okay, that's all for me. Thank you. Yes. Any question?
No.
Sorry. Oh, sorry, Fatia. Sorry, I've been talking, cuma I mute, tak perasan. Actually, the technique that you show is not something that we routinely practice in Malaysia. Kau dengar ke?
Dengar.
Because we don't actually cut tau the PICC. I dah kerja dekat about 4 hospital. None of the hospital yang actually cut the PICC. Is you insert the PICC into the length that you desired, and then the remaining you just twirl dekat dia punya entry site tu, and then you secure there. You tak potong tau PICC. Problem is kalau you potong, takut dia sharp end. So PICC the end is quite blunt tau. So kalau you potong, dia akan dia sharp end. Takut you inject the vessel. And then kalau you guna primary cast, dia ada guide wire. So kalau you potong, rosak lah guide wire tu. Saya pun tak sure lah. Memang dalam video dia kata potong
Dalam video tu potong.
Where did you get the video? Your reference? Hello?
Jawab doktor.
Okay. Lagi satu kan, by the way. If we can, I think the video is the ideal situation lah. The type that catheter that we are using, the ICT that we are using now, I don't think it's as good as that one. Because yang tu you boleh, the introducer tu you boleh split into two. That's very canggih tau. Kita punya macam, entahlah. And it's not that easy tau untuk masuk PIC. It usually takes about 1 to 2, even 4 hours untuk masuk PICC. Kan macam orang tu buat macam 5 minutes kan? No, it's not. Dia sangat susah tau PICC, especially kalau in small baby. Kalau you guna primary cast tu mungkin senang sikit lah. Tapi kalau ada catheter memang susah. Especially in units. Tapi tak apalah, reference tu tak apalah. Nanti I try tanya Dr. Syed whether memang kita cut PICC. So I tak tahu yang kita cut. I don't think we actually cut the PICC. Anyway, got any other questions? Anyone?
Doktor, the video is from the New England Medicine Journal.
New England Journal Okay, NJM. Okay lah, okay lah, tak apalah macam tu. It's okay. But later lah, kalau you've got the opportunity to look, to observe us insert PICC, then you notice it's definitely not like the one in the video lah. It's bloody, it's difficult. It's difficult, it's not easy. And we don't actually cut lah the catheter. Anyway, good job. Later can you send your slides? Nanti I bagi markah. Slide you dah ada kan, tapi nanti I tengok balik the slides and I'll give you guys the mark. Any other question? Last questions?
Doctor, I have a question. Between PICC and central venous lines, which one is more commonly used in Malaysia hospital practice?
Okay, it depends. Okay, actually in adult, okay, we used to do PICC a lot. Like when I was houseman kan, kita memang buat PICC. PICC houseman memang buat. Problem until recently, I think in 2013, company yang provide PICC untuk adult kan, they withdraw all dia punya product sebab ada issue with safety ke benda lah, something material punya problem. So since then, dah tak guna dah PICC. In fact, I never seen any PICC inserted in adult. Tapi last I pun about pediatric. Rasa memang dah tak guna dah PICC in adult. In pediatric, we do use PICC. In fact, I prefer PICC to femoral line, because PICC is less risk of infection. And patient with PICC, patient boleh jalan-jalan semua tau, can walk around. With femoral line, patient will be restricted to the bed lah, bed restricted. In terms of frequency in neonates, it's almost always umbilical catheter followed by PICC. Unless kalau patient going for surgery atau patient for resuscitation, then we will insert femoral line. Alternatively masuk internal jugular. Tapi kalau just untuk feeding, untuk medication, kita buat PICC. To in neonates. In older children, it's almost always femoral. Almost never PICC in older children. Because not many hospital ada PICC untuk older children. The big size PICC tu susah dapat because it's very expensive. We do have here. Dekat sini kita ada PICC double lumen, triple lumen, single lumen PICC yang kita guna untuk older children lah. Tapi most people dia buat femoral line untuk older children. Okay, does that answer your question?
Okay, faham. Yes, Doktor.
Okay. Okay, any questions? Any other questions? Okay, kalau tak ada dah habis lah. So kita tangguh kelas dulu. I think kalau next time kalau ada kelas lah, like again and again lah. Macam I dah tak boleh catch up with the classes lah. Okay, so kita end here lah. Okay, kita tangguh dengan tasbih kafarah dan suratul As.
Okay, thank you, Doktor.
Okay, Assalamualaikum.
Doktor, this is actually our last class.
Oh, ya ke? Lepas ni apa? Face to face?
Sebab next week, next week group lain.
Bukan medical kan? You buat medical kan?
Buat internal medicine.
Lepas tu datang balik kan untuk face to face?
Tapi nanti face to face start IM, kami start IM dulu baru fit.
Okay. Tak apalah. Anyway, all the best. Okay, thanks a lot.
Thank you, Doktor.
Okay.
Thank you, Doktor.
Baru nak berkenalan.
Thank you, Doktor. Thank you, Doktor.
Okay. Thank you. Bye.